you're joining us from. Uh, we're lucky today to, well, first, it's been a couple of months that are very interesting in transplantation. With transplantation, a lot of really exciting stuff going on in transplant. And today we're going to talk about a very important topic, which is transplant onconephrology. I think a lot of us, know a lot about transplant and onconephrology separately, but the sort of cool field of transplant onconephrology is sort of an emerging field, and we're lucky to have some experts today. So I think first the first speaker is gonna be Dr. Naoka Murakami. Dr. Murakami, who I know very well and trained under. She's a transplant nephrologist and onconephrologist at the Brigham and Women's Hospital. And yes, and so Dr. Germaine Wong is a professor of clinical epidemiology at the University of Sydney, and she's a clinical transplant nephrologist, where she's a director of renal and transplantation medicine.
All right. Thank you so much, Ayman, for a kind introduction. I'm super excited to be here with worldly renowned Dr. Germaine Wong to talk about the updates on the transplant onconephrology. This is my disclosure. Today, we're going to learn and understand the transplant candidacy of patients with a history of cancer before the transplant, and then understand the increased risk of cancer post-transplant. And I'll touch on the novel therapies, including checkpoint blockade and CAR-T for the kidney transplant recipients. So as you know, cancer is a major cause of death after kidney transplantation. You see the graph on the left-hand side, the cause of death in dialysis patients, and on the right-hand side, the cause of death of transplant patients. Cardiovascular cause of death is approximately half of the cause for dialysis patients, but on the right-hand side, as you can see, malignancy is now second leading cause of death in this population, so we should work on it. And cancer risk is higher after the transplant. By the way, I'm kind of highlighting the important slides with the star mark on the right-hand side. So this is the key slide, one of the key slides I'm presenting from Dr. Adler and then Dr. Wong, published in CJS a couple of years ago, showing the standardized increase ratio. The post-transplant cancers are very high, especially virus-driven skin cancers such as Kaposi sarcoma and non-melanoma skin cancer. And then also the mortality risk is high for post-transplant cancers, including PTLD, non-Hodgkin's lymphoma, and kidney cancer and melanoma. Deaths due to cancer post-transplant didn't decline, unfortunately. This is the graph showing the 10-year cause-specific mortality hazard ratio with a reference year of 1996. As you can see here, the infectious or cardiovascular mortality hazard ratio decreased over time, but malignancy mortality, unfortunately, increased for the past couple of years, so we should do better. So as Ayman mentioned, obviously with the increased risk of cancer, it's very important to think about, onconephrology in the kidney transplantation as well. And we as transplant nephrologists, without, mention explicitly as onconephrology, but we always touch the cancer care pre and post transplant. So today we're going to talk about the journey of the kidney transplant patient, starting from pre-transplant, post-transplant, cancer screening and management of immunosuppression, as well as some newer cancer treatment. So starting with the pre-transplant care for the patients with a ESRD. I'm going to start with one case, 62-year-old woman with ESKD due to type 2 diabetes. She's on dialysis and being evaluated for the kidney transplant. As a part of the screening, she had a mammogram which showed a suspicious mass in her right breast. Ultrasound-guided biopsy showed a ductal carcinoma in situ. She was otherwise cleared for other evaluations, including cardiac testing, and she underwent the right mastectomy and cleared by her oncologist that she doesn't need further intervention. So the question now to us for the transplant nephrologist, how long does she need to wait before being on a transplant wait list? No wait time, or we should wait for 2 years, 5 years, or she cannot be a candidate for a transplant because of the history of cancer? So the answer is A. So there's a myth that the patient cannot be a candidate if they had a history of cancer, but it's not true. So this is another key slide about the cancer-free wait time. So there have been, concern about the cancer recurrence post-transplant. It does happen, but with the advancement of the cancer therapy, it's very important to reassess the risk of recurrence in the contemporary era with